The question must be articulated in measurable terms. There is a mix of qualitative and quantitative design. Participation of the people whom you are surveying is crucial. Participation means there must be honest participation. Methodology must be clear, but there should be some amount of flexibility because you never know what kind of question is going to come out. Outcomes must be meaningful and focused, and there must be a clear course of action. So what would be the outcomes? For instance, if we are looking at knowledge at a KFP questionnaire of knowledge about physiotherapy management in acute spinal cord injury. Now, the person who is setting this question or survey would have certain opinions or certain ideas or certain knowledge about spinal cord injury and how physios must approach a patient with spinal cord injury. This might not be the same kind of practice or knowledge or understanding that the participants in the survey may be having. Because if you are looking at what is the knowledge, attitudes, and practice of physios in India, then you have to select people from across India. So depending on the different type of facilities available in different areas, the knowledge, depending on the education level, etc., knowledge may be different. Attitudes will definitely be different because if you have typically, I mean, you know, you want to do ortho, that is your area of interest, but you're getting stuck with spinal cord injury, then your attitude towards these patients with spinal cord injury may be different. It may not be the same as someone who has joined physiotherapy for neuro. Now, knowledge and attitudes may be good, but practice may not happen according to guidelines. How does this happen? This is a chasm between your theory and practice. Theory, all of us are reading the same textbooks or the same journals. Attitudes, most of us, I'm sure if you are in the healthcare profession, have positive attitudes towards people with disability. But the practice has other inputs like contextual factors. So if you know that you're supposed to do till table standing, for example, very simple thing, and they as soon as they're medically stable. But if you do not have a proper till table, or you do not have people there, then it is not knowledge, it is not attitude. You want to do it, but your practice is different. So these are things that this information you can get out of a KP questionnaire. So the K part is based in theoretical knowledge or skills or something like that. The attitude is what the person, feelings and behavior. Feelings and attitudes, and practice is what they're actually doing. Both of the rest being okay, this is what you're looking at. The most common questionnaires that are standardized questionnaires that are available for KAP questionnaires are for pain. You have the PABS, you have RNPQ, you have rehab professionals, attitudes of pain, etc. These are standardized questionnaires which have been able to identify these constructs within the person, within the person's answers to the questionnaire. So that the outcomes must be meaningful. So if you simply ask an open-ended question like, do you think spinal cord injury, patients with spinal cord injury must be made to stand on the third day? Now, some people may say yes, some people may say no. There might be not much information on that. So you may have to give more information, third day, etc., and then other descriptors, and say what would be the most appropriate thing. What are the three most important things that you would do to this patient, or something like that. That would be able to analyze the person's knowledge. Attitudes is also there because it's a psychological construct. These are also made, and then practices. You want to know. They have everything, they have all the infrastructure, they have the knowledge, they have the attitude, but because of time or something, they're not doing what they want to do. So if you give educational vignette and say, see, people, if you give evidence or something like that, maybe the practice will change, maybe people take greater effort. So this must be able to come out in your question. So that That is why the outcomes for all these questionnaires. So these questionnaires must be meaningful, it must be focused, it must be, if possible, standardized, and it must be meaningful to your context. So since attitudes and practice are highly contextual, the questionnaires must be meaningful to your context. And then you must have a clear course of action. When you have an answerable question, you need to break it down into stepwise questions. So you focus on one aspect at a time. So if the question is based on community's needs, knowledge, attitudes, and beliefs, the initial step would be to articulate a question. Initial step to articulate a question would be to get a Delphi survey. So when you do a Delphi survey or a focus group interview to evaluate the community's needs, you must not mix up the knowledge, attitudes, and beliefs. So first we talk about knowledge. So what is the knowledge that you expect a person who's treating spinal cord injury to have? So tell me the three most important things or five most important things. So that is how the knowledge is assessed. Then the attitudes would be likewise assessed and beliefs likewise assessed. You cannot, attitudes and beliefs are same. So one attitude may be, once it is a total spinal cord injury, no matter of no amount of physiotherapy is going to make any difference in their lives. So you already have this attitude. Why? Perhaps because of your attitude that living with a spinal cord injury, living with a disability is not worthwhile. You should either be cured or you should die or something. So if you have such an attitude, then you're not obviously going to be able to put your knowledge into practice because you do not believe that the knowledge is relevant. So when you're doing a Delphi survey, it is necessary for you to use, divide this into groups. So you have, divide the questions or the survey into sections: knowledge, attitudes and beliefs, and practice. The question must be important to the participants, and you have to avoid top-down approach. You need to, like I said, it needs to be a Delphi survey. So you need to have people who are going to be the focus of your final questionnaire. Must be the ones. It must be the same kind of people who will give you the questions. For instance, will awareness improve the incidence of waterborne diseases in a village? So step one is, what is the community belief about diarrhea among children? So they may believe that it is because of eating too much protein. They might believe that it is evil eye. They might believe so many things. So if that is the belief, then telling that you should boil your water doesn't make any sense because there is no connection between the activity you are telling and the beliefs that the community has. This is necessary to identify. So qualitative methodology would be open-ended questions. First, to identify the correct beliefs and the wrong beliefs. Analyze respondent characteristics. So people with 10th standard education may be having the correct beliefs. Those who are illiterate may be having the wrong beliefs and so on. So when you make the survey questions, you may need to make two sets of questions. Then you want to know what are the unique characteristics of incorrect beliefs. Now, why do they believe these things? Is it because there is a witch doctor or a guide or someone who is giving them this information? Is that the reason? In which case, the obvious intervention would be to go and change the belief through that guide or the witch doctor. Because if you correct his belief, he will pass it on to everyone else because he has clout within the community. So these are the things you need to understand. Then what are the methods that can be employed to increase accurate awareness in these respondents? That is one of them. Maybe you need to catch people of influence within the community. If there is, if you are looking at different beliefs with literate and illiterate, you may want to do pamphlets for the literate, but you may want to do street plays for the illiterate and so on. Then you need to employ methods and evaluate the understanding. Finally, you need to do repeated analysis to assess the impact of education on knowledge, attitudes, and practice. So the question of will awareness improve the incidence of waterborne diseases in a village can only be answered if all these 5 steps are successful. And there are many barriers to having a successful completion of this kind of questionnaire. So that is one thing about community-based research. The other community-based research are your typical surveys, epidemiological research, the typical ones that everybody has learned. So those would be epidemiology, your basic survey. You take questionnaire and go and see how many of you have, how many people in this village have diabetes, how many have hypertension, what are the factors associated with it. Is it because of food habits? Is it because of physical activity? So on and so forth. That's a basic survey, which I'm not going to go into. Now, of course, there is another sort of community research that you can do. Currently, this has been the focus a lot. That is disaster management. Because the last time there was the Chennai floods, there were a lot of heartbreaking stories about old people and disabled people not being rescued because the rescuers did not know that they were disabled and that they were old and so on. So this is where now the government is also pushing, and Ministry of Social Justice is also pushing to map people with disability. So this is mainly for disaster management. If a village is marooned and you have to give food, you have to throw packets. You would have to throw packets also to specific areas where there are disabled families, because they will not be able to come out and get it. This can be done by geographical information systems, GIS mapping. So a lot of GIS mapping now we are doing as a regular part of our CBR program in JSS. We do GIS since the last 2 years. We have been doing a GIS mapping of the villages. So we finished whatever villages we can in 1 week. So that hopefully over the next 10 years, Mysore will be mapped for disability. So now, how we're going about this is by using an app called Fulcrum app. Now there are many platforms for GIS, but Fulcrum is the one that we are using. That's all. So there are free apps also. There are free platforms also which you can use for GIS mapping. So that would be towards policy. That is one sort of research towards policy. Then there is community participatory research. After the KAP, now what happens? After the KAP happens, now if the community believes that their knowledge is not adequate, their attitudes are wrong, and their practice is not good, attitudes and beliefs are not good, then you need to start some sort of training. So for this training, you need community participation, because the interest and the training must come from within the community, because there are unique characteristics. That is the definition of a community. Community is a group of people with unique characteristics that they share. So the training must naturally come from these people themselves, from the community themselves. So that is community participatory research. All of this is mainly based on policy making or educational strategies. Again, policy making. So if you have a village which has a large number of children with locomotor disability, so the probably the school department would like to have one floor schools with wheelchair accessibility, because those are the needs of the community. Like that. So it is not mainly for policy and policy and for comparing countries and so on. So that finishes methodology. Now coming to research designs. Now coming to developing methodology. So what are the parts of a methodology? Parts of the methodology, most important parts of the methodology are the study design. So based on the study design is how you're going to decide how many samples you need and so on. Then you need a sampling strategy, because sampling strategy must be as close to probability sampling as possible. Probability may not be possible, random may not be possible, but at least as close to decrease as much bias as possible. Then you need sample size. Then you need the outcome measures. Outcome measures that will be employed must be very strong. It must be robust. It must be sensitive, specific, depending on your question. If you're trying to identify a disease or something like that, then your outcome measures must be very sensitive. If you're trying to see odds ratio, those kind of things, you need to know sensitivity, specificity. If you are going to employ an intervention and then see what happens after that, then you require a tool that is very responsive. So outcomes that must be employed must be first researched or reviewed to make sure that the outcomes are robust in their original setting, and that they can be employed in your setting with the same measurement characteristics intact. Then you come up with a procedure for data collection, which everybody is familiar with. You will get ethical committee clearance, you will get informed consent, you will you will screen for inclusion, exclusion, etc., etc. A regular procedure. And then the data analysis. So in the methodology, you design your sampling, your outcome and your data analysis are one continuum. So these are all related to one another. The procedure for data collection is probably the least important. The outcomes, depending on the level of measurement, etc. The design, depending on what you're trying to find out. These are the things these are the factors which will inform your data analysis. What kind of data analysis do you want to involve? So are you looking at a simple pre-post design? Are you simply going to see if this improved or not? You're not really worried about what percentage, what variables and so on. Then you can do a simple t-test. If not, you will be doing, anyway, data analysis will be coming in future sessions. But this must be decided upfront. And you want to know the number of participants you plan to include, because if the numbers are very less, then you may not be able to do parametric statistics. You have to do non-parametric statistics because you're not expecting normal distribution. You want to check all methods to control for bias and the procedure that will be done. So methods, like I said, are dependent on the question and the design. If the design is qualitative, you will employ methods that are less robust but more descriptive, because qualitative designs, if you will remember, are exploratory designs. So you're trying to find out why something happened, why this phenomena is there. So for that, you need more description. So qualitative designs are descriptive in nature, and therefore, just because of the way qualitative designs are, you cannot have too many participants. So the number of participants that you will be looking at will be in the neighborhood of 5 to 11. That's all you need, because the sampling criteria here is until data saturation. What is data saturation? Data saturation is if someone tells you, I ask, what do you feel about being a woman in India? So I say, being a woman in India is very empowering. I am happy, I can know what I want, there's independence, it's a free country, and so on. The next person may say, being a woman in India is disabling because you can't do anything. For everything, you have to ask your father's or husband's permission, and so on. The third person may echo my opinion. Fourth person may echo the other person's opinion. So you have reached saturation because there's no new thing that's coming. One is saying empowering, one is saying disempowering. That's it. There's nothing new that is coming. So that is called data saturation. So once you don't get any new information, you stop. So this number is usually in the, like I said, in the neighborhood of 5 to 11. In observational designs, robust outcomes are required because there is no randomization in this. You're simply observing the people the way they are, and hence you require large number of participants. So cohorts are usually very large. If the experimental design is very strong, there are lots of controls for bias, then you require fewer participants. One important case in point here is if the participants act as their own controls, like in repeated measures design, the number of participants, the number of participants required become less because the bias is controlled in many ways. When choosing measurements, I already talked about this. Participant characteristics. Criteria that you employ for inclusion exclusion must adequately address the research question based on what you want to know. If you make the criteria too stringent, there might be no generalizability. If you make it too lax, it might not be answering a question. So you must think about the participant criteria. You cannot simply write everyone who does not have neurological, cardiothoracic, and systemic disease. I mean, these are things that are sometimes necessary, but not always necessary. So you must think about it. The number must be adequate based on the outcome of interest in these properties. See, research design, sampling is based on research design, but there is also outcome. So if the outcome requires, if you think the outcome requires large number of people, you require to take more than you need to take more than your minimum sample size. And like I said, characteristics must be appropriate, not too narrow and not too vague. Procedure for data collection must be clear and descriptive. The main purpose of this procedure is so that the person who is reading your research knows exactly what you did, so that they can replicate it if necessary. So there is nothing left to the imagination. So if you say the patient was disrobed and the bony prominences were marked, then we know that you took goniometry like that, that you did not do it on top of the road, so that error is not there. So there must be as much clarity as possible, must be descriptive. The reader must be able to know exactly what you did from your description. So it must be like a recipe. It must be like a description of do this, next, and flowchart is always necessary. If there are multiple steps, you must say the first phase of the study procedure, second phase, third phase, and so on. For instance, if you want to validate a measurement tool, an outcome measure before the start of the main study, then this should be as a separate section. So you say validation of measurement tools was done using this, and then you do your main study and so on. Data analysis statistics important to plan and envision before you start the procedure. You should know what type of measurements is used. You need to know how many participants. So can you use that kind of data analysis? You want to decide right in the beginning, priorly, what are the relationships of interest? Do you want to know correlation? Do you want to know comparison? What do you want to know? So these things are necessary to know. And final answer to the research question. So data analysis must be such that it answers your research question. So there must be connection between your objectives, your methodology, data analysis, and your results. That ends this. So, there are two people. If there are any questions, I can answer. Any questions? I guess not. Then thank you and good evening. Bye. Merry Christmas, Lena.
Sorry?
I said Merry
Hello?
Christmas. I said Merry Christmas.
Wish you the same, ma'am.
Okay, bye.
Bye bye.